Hello and welcome everyone to another episode of Facebook Live with Dr. Joe. My name is Joseph Mikhael. I am the Chief Medical Officer of the International Myeloma Foundation, and I'm absolutely thrilled to be able to join you today to think a little bit together about multiple myeloma in this very special month. So I'm sure many of you are familiar with this, but we are in the middle of Myeloma Action Month. Sometimes it's been known as, and the IMF actually initially launched it as Myeloma Awareness Month, and it's okay to still call it Myeloma Awareness Month, but we prefer action because it is one thing to be aware of the problem, it's another to take action. And so we wanted to make sure that we encourage people to take action in multiple myeloma. And the IMF, or the International Myeloma Foundation, for over 32 years has been taking action, as it were, to try and find a cure for myeloma. And while we seek the cure, to improve the lives of those patients that have it, and indeed their families and their care partners as they go through this journey of multiple myeloma. So this year, our Myeloma Action Month theme has been My Myeloma Story, or Myeloma Story, using the MY in the word myeloma to mean My Myeloma Story. And we've been encouraging people all over the world to share their story. And it's been remarkable how many people indeed have been doing that. And we've been enjoying hearing about how people are really conquering this disease and how they are fighting against it. And we're so grateful for that. And we would appreciate if you shared that with us. And you can go to mam.myeloma.org and tell us more about your myeloma story, or indeed simply to myeloma.org to learn more about multiple myeloma. If you're not familiar with myeloma, I'm just very briefly going to give you a little bit of an outline of the disease and then dive into Dr. Joe's myeloma story. Why am I a myeloma doctor? Why have I tried to devote so much of my life to fighting this disease? And then we're going to open up for questions. So there is a comment box there, so feel free to pepper the questions in. Some of them are already starting to come in, and I'll be sure that I will have time to get to them as much as I can. So quickly, multiple myeloma is really a cancer of the blood, or specifically the factory of our blood, which is what we call the bone marrow. So inside our bones is where we make our blood. And there's all sorts of different cells in there that are really important, of which one is called the plasma cell. Now, you may not recognize the plasma cell, but we've been talking about the plasma cell during the pandemic and beyond because it's the cell that makes antibodies for us. So when you get a vaccination, or even if you're just infected with something, your body wants to make what we call antibodies to help you fight it and to protect you from it in the future. And those are made by the plasma cells. But when plasma cells become cancerous, then we have, sadly, the situation of multiple myeloma, where now instead of making good antibodies, the body makes bad antibodies, as it were, and they can attack the kidney and the bones and other parts of the body, and the rest of the factory doesn't work very well. So myeloma is a disease, therefore, that can really affect multiple organs in patients. The average age of diagnosis is nearly 70, but is significantly younger in African American patients and in Hispanic patients. The disease is actually twice as common in the African American population, and if you're interested in understanding, unfortunately, the health disparities within multiple myeloma within the African American community, then go to myeloma.org, or specifically empower.myeloma.org, empower, the letter M and the word power, where you can see how the IMF is dedicated to health equity and how we've been working in this area. As a man who is African American, this is of particular importance to me personally, but also important to me professionally, as there has been a terrible inequity in this country where black patients with myeloma have half the survival of white patients with myeloma. But overall, we've seen tremendous improvement in survival in myeloma. Patients are living much longer than ever before. Most patients will live over a decade now with multiple myeloma. And that's been the result of some incredible therapies that I'm sure we'll get into chatting about in just a minute. So that's the basics of multiple myeloma. The last comment I'll make about myeloma, for those who aren't as familiar with it, is it can often be difficult to make the diagnosis of myeloma because people don't come in saying, I have more plasma cells in my bone marrow. Nobody knows that. Patients initially typically present with fatigue or with bone pain, and sometimes with changes in some blood counts, namely anemia or low red blood cell count. And so one of the important features of Myeloma Action Month is to raise awareness of myeloma so that when people have signs and symptoms like that, they can speak to their doctor to get tested. All right, so let's dive in. What is Dr. Joe's myeloma story? Well, everyone has reasons for why they do what they do. For me, I came from a family of doctors, and so I actually didn't want to be a doctor because both my parents and my brother were doctors, and I thought, you know what, I'm not going to do that. Maybe I'll become a lawyer and protect them, or maybe I'll do something else. But as I started to learn the field of medicine, I wanted to become a doctor. I wanted to care for the patients who were the sickest. And indeed, that's what really led me to multiple myeloma. As I was a medical student, as a resident, and I started to see the devastating effects of myeloma, I really wanted to care for those patients that were the sickest. And then what really pushed me in that direction is working with some amazing doctors when I was trained in Canada who were very dedicated to multiple myeloma, who were my mentors. And it really culminated in one day when I was a resident. So I had finished medical school, but I was still a resident physician. And I was called to the emergency room to help understand a case of a young man who had presented to the emergency room after actually he'd been playing hockey. You know, hockey's a big deal for Canadians. And he just had so much more pain than would have been expected from when he played that game. And the emergency room doctor put up the x-ray for me, and sadly, this young man had holes throughout so many of his bones in the back. It was a terrible picture of an x-ray. And I remember speaking to the emergency room doctor and saying, I think we have to think about multiple myeloma in this case. And sure enough, it was multiple myeloma. The shocking feature, and I did talk to him before this meeting, is that it turned out to be one of my friends from high school. And so Rich, who's an amazing man, now 26 years later, is still fighting multiple myeloma. He had some very intense treatments, and it's just remarkable to see. And he's been a tremendous motivation to me and to so many others. So if you are listening, Rich, thank you for being who you are, brother. You're amazing. And so that was really what propelled me into the field of multiple myeloma, and I'm very grateful that I've been able to work in this field. So you've heard a little bit about myeloma. You've heard a little bit about my story. Well, now let's start thinking a little bit about the questions that people are sending in. So they're already starting to come in, which is great. Let's talk about this first question that someone has sent in saying, if MRD negative and PET scan indicates no disease, can going off maintenance drug be considered? Have been on Revlimid for 5 years. So thank you for this question. For anonymous sake, I'll just use letters of people's names. So LW sent us this note. And so you're asking an extraordinary question, actually. So typically in myeloma, we're giving treatment, whether patients are eligible or not for stem cell transplant, influences whether or not we give a transplant. And then they often go on to maintenance therapy, and most commonly with the drug Revlimid, a generic name lenalidomide. And right now, the best evidence we have is to give lenalidomide for at least 4 to 5 years. This was even actually just reiterated at a meeting in December where our friends from the UK presented longer-term follow-up of patients who were given lenalidomide maintenance, and there was still a benefit even in MRD negative or minimal residual disease, or some people call it measurable residual disease, negativity, which means we can't find any trace of the myeloma. Typically, at least 1 in a million cells, we can't detect any myeloma. That those patients benefited from at least 4 to 5 years of maintenance. But at the 5-year mark, we have to say we don't really know for sure. And the myeloma community is a little split on this. There are some who will be purists and say, you know what, we've had patients on maintenance lenalidomide for 7, 10, 12 years. Please continue it. Others might say, look, you know, if the disease is under great control for this long, it's reasonable to come off. And so I think it's worth having a conversation. Of course, I can't give direct medical advice per se, but it's worth having a conversation with your physician about this exact situation. Because once people have hit the 5 years, if it really is as negative as you're describing, if there aren't any what we would call high-risk features, which we tend to be nervous about because that means the disease can come back more quickly, then it may be very legitimate to do that. And it's really remarkable now with our therapies in myeloma that there are patients that we can do this to. And I would hope that with time, we're going to develop more and more stopping rules, partly helped by the MRD testing or minimal residual disease testing to know if someone has no measurable disease, to be able to stop therapy. I say it all the time. I just chatted with a physician right before this call. I said, my favorite therapy in patients is nada, nothing. And if we can get more patients on no treatment, that would be very good. So that is that is a really excellent question. So thank you very much for that. Oh, wow, the questions are pouring in. I better answer them more quickly. Is it possible to detect these circulating DNA in myeloma with MRD negative by using mass spectrometry, I think is what they mean, during treatment periods? Well, thank you, YC, for that great question. The short answer is we're working towards that. It's not as easy as we might think. There are some cancers in which instead of having to find the tumor, we can measure tiny bits of DNA that are circulating in the blood that are connected to that cancer. And sometimes it allows us to see if there's still residual disease, but also to detect an early relapse in some of those solid tumors and other cancers. We're trying to do the same in myeloma, and there's some great work going on. Our colleagues in Australia that have been part of the Black Swan Research Initiative, which is what the research arm of the IMF has been doing. But it's really not completed yet, and it's not as simple as that. There's some work that we do even in the lab that I'm affiliated with here in Phoenix at TGen, looking at not so much the circulating DNA, but even just very, very few tiny amounts of circulating plasma cells that can be detected. And that's really quite prognostic. So this is a field that is evolving, and I'm going to suggest has actually become very important, because one thing patients don't enjoy is having multiple bone marrows. And so if there's a way to detect the disease in the blood instead of having to do a bone marrow, I think we will want to be doing that, and I think we're going to be doing that more so. Another question from KA. I'm interested in the rare types of multiple myeloma. No secretory, or probably what they mean is where we're not releasing the protein in the blood, multiple myeloma. They're asking, is there treatment for this? So thank you for a great question. So as I mentioned in the start, myeloma is a complicated disease where these plasma cells grow in the bone marrow and they release that bad antibody into the blood. And typically the antibody is entirely intact, and we call that an M spike, because there's two parts to the antibody, what's called the heavy chain and the light chain, and those are connected and they stay intact. About 20% of patients will only have light chains. The majority of patients actually have both measurable, but about 20% have light chains only. And then there's a tiny fraction of patients, about 1%, that have what we call non-secretory myeloma, where we can't measure anything. And it's tricky because we don't detect the disease as well as we would typically do in the blood or in the urine. And so very often it turns into a situation where if there's no other measurable disease, we have to be repeating bone marrows. Sometimes on a PET scan or some kind of imaging scan, we can detect disease elsewhere. But in answer to your question, we do typically treat it like every other myeloma. It's just that we have to be more careful in determining how we monitor progress, because we don't monitor it just by the usual blood tests that we typically would. And unfortunately, it often means at times patients that have non-secretory myeloma may not be eligible for certain clinical trials where there is a mandate to ensure that we can more easily, if you will, measure the disease. Okay, more questions coming in. Also some really nice comments. I love this when someone says, I was diagnosed 8th of March and started RVD treatment. Someone had said that they've been treated many years ago, but then someone has just joined in and said, JC says, I was diagnosed 8th of March and started RVD treatment today. Well, JC, I'm sorry to hear that you were diagnosed with myeloma, but I'm thankful that you're undergoing treatment, and what appears to be good treatment with a combination of drugs. JC, let me remind you that you have, I'm sure, your own local support network, but you've got an army of people who want to support you here at the IMF and in many other places across the country and the world, frankly. So please feel free to make use of the resources of the IMF, our website, our info line. People can always call the info line if they have questions. It's 1-800-452-CURE, CURE, or the number's 2873. Or, of course, you can learn on our website about finding a support group. We have over 150 support groups across the country that can bolster your understanding of the disease and support you through your journey with multiple myeloma. I'm always want to support, in particular, those patients that are diagnosed early on, to be connected so that we can support them in that journey. Here's another great comment. Thank you, Dr. Joe. 26 year thriver in your story is such a great testament to the amazing work being done by myeloma experts around the world. Thank you, RMB, for your beautiful comment. And we're grateful. We're really a united force against myeloma, with so many of us that are in this field. And it's great to see that individuals like my friend, 26 years later, can still continue to fight this disease. Okay, I am considering CAR T cell therapy and or bispecific treatment. Can I do bispecifics as bridging? Um, oh, sorry, that just jumped there. Can I do bispecifics as bridging? Um, so this actually leads to a really good question around what are these new treatments that I think I can explain a little bit, but also um, explain how we can sequence them. Because the question is here, can I do bispecifics as bridging? Can I do bispecifics after CAR T? So it's ironic. I was doing a podcast on this very issue this morning, discussing this with a few other experts in myeloma. So very quickly, CAR T cell therapy is where we take T cells or some kind of immune cell out of a patient, and we basically train them to know what the myeloma looks like. So we're taking someone's own immune system, training them to recognize their myeloma, multiplying them in a lab, and then giving them back to the patient. And it's really been arguably the most effective treatment we've ever had in myeloma. Unprecedented response rates, over 80, 90, and even 95% of patients respond to it. Bispecific therapy is such that we similarly use someone's immune system, but instead of having to collect T cells out of them, we give patients a drug that has two arms. That's why they're called bispecific. With one arm, it grabs onto the myeloma, the other arm grabs onto a local T cell, or sometimes now other cells, but we'll keep it simple with a T cell, and engages that T cell, introduces them. How you doing? Introduce the T cell so that it can be activated and help destroy that myeloma. And the question you're asking is, can you really go back and forth between the two? And the simple answer is it can be done. And we've been doing it in many patients because sometimes we have very limited options. Right now, the two CAR T cell therapies we have and the one bispecific we have that are FDA approved all have the same target on myeloma, what's called BCMA. And we do know that we can repeat a BCMA treatment. So someone can get a CAR T and then a bispecific, or bispecific then CAR T. It may not always be ideal to immediately follow one BCMA treatment by another, just by virtue of the fact that response rates go down a little bit. But very often, if those are the only options we have, it is legitimate to pursue that. We are also developing both CAR Ts and bispecifics with different targets. There are two other new targets. I know they all sound like license plates, but one's GPRC5D and one's FCRH5, and we're developing drugs of those targets that can also be used probably in a better sequence. But also there are other BCMA targeted drugs that are coming also that do work a little bit differently. We've learned that BCMA is not that simple, that we can target BCMA a little bit differently, and we may often be able to use one BCMA drug immediately after another. So thank you for that really, really good question. That was great. Is there a difference in outcome being 3 weeks on versus continuous Revlimid? Well, thank you, MVL, for that great question. It's interesting because different clinical trials back in the day in different countries, even how they've indicated the maintenance Revlimid, have used these two strategies. Every day, 28 days in a row, and just restart the next day, or just go on for 21 days and take 7 days off. I think most of the myeloma community has concluded that there really isn't a big difference in outcome. I can share that I tend to favor 3 weeks on, 1 week off for a few reasons. One, it gives people a little bit of a break, but it also gives us an indication if some of the symptoms that people are experiencing are really connected to the drug or not. Like some of the things we may see, like fatigue or diarrhea or muscle cramping, that sometimes if that really gets better in the week off, then we know that it really is connected to the drug, and sometimes we may want to make dose adjustments because of that. All right, Here's another question. How long should CAR T cell last on average? Thanks, PG, for a great question. Really good question. Um, it's really hard to give exact averages because it really depends on when it's used, in whom it's used, and which one is used. Because right now we have two different CAR T cell therapies. One is called ida-cel, or the trade name is Abecma, and one is cilta-cel, a trade name Carvykti. And it really varies. In the original clinical trials with the ida-cel product, it lasted. People had about 9 months on average of remission. In the cilta-cel, it was longer, came a little bit later, but it was really out to 2 years. What we're seeing now in sort of real world clinical practice is a huge variation. For some people, it may last only 6 months. For others, have gone well beyond 2 and 3 years. So lots of factors go into it. But I will say that, as I mentioned earlier, it's one of the most effective therapies we've ever used, if not the most effective, especially in patients that have had so many lines of treatment. And so we really have seen very deep responses and often very durable responses. And so if it is something that is potentially available and someone's eligible for it, it's worth having that discussion and looking through it so that they can understand it. But it's hard to give an exact number. And that's one of the realities of myeloma. Myeloma is really a very different disease in almost every patient. Sometimes I say it's called multiple myeloma for a reason because it can be really quite different. Okay, we have someone who sent many questions here, which is great. How can I get help? What is the treatment? I have just a few lesions. Well, thanks, KA, for that. And I think that's obviously very important to discuss with your physician. But there are some interesting points to make here, namely that myeloma can be part of what we call a spectrum of diseases, where people can have a pre-myeloma condition called MGUS, or monoclonal gammopathy of undetermined significance, or something called smoldering myeloma, where there are plasma cells that are abnormal in the bone marrow, but it hasn't really grown to a point where we would typically treat it, and then there's true active myeloma. And so, but if someone has active myeloma, even if there's just a few lesions, if they really are lesions that are in the bone that we think are related to the myeloma, then that typically means that someone really does have to get the full treatment of myeloma. We typically don't sort of partially treat myeloma. We either try to decide, do you have active myeloma or not? And if you do, then we proceed with treatment. So hopefully that will help as you think that through. Here's someone who says, I did BMT or bone marrow transplant 3 months ago. This is AA. Now on consolidation. PTH was found above normal last week. Calcium, potassium alkaphos, and vitamin D are okay. Magnesium was always normal. Any other investigation needed? That's a great question. A bit specific. It's hard for me to give a lot of specifics to this. There are different reasons why the hormonal system can be affected in patients who have had a transplant. Sometimes this is a function of the high dose treatment that we've been given, and we've seen in some patients there can be if you will, a stunning of some of the endocrine system or the hormonal system that can then kick back into gear and be okay. That's something that will probably have to be followed a little bit more. It sounds like the key testing was done, especially looking at those levels that you indicated, but that's something that needs to be followed because that may require more intervention, may even need an endocrinologist or a specialist in the area to evaluate it more fully. And by the way, our patient I mentioned earlier was newly diagnosed, said, I am getting such great support from this group. You will be hearing from me more. Well, we're thankful for that, JC. We're happy to try and support you any and every way we can. I hope you continue to do well, my friend. Okay, wow, the questions are just streaming in, and I've got 6 minutes left. So Dr. Joe's going to put it into higher gear here and try and answer his question as possible. Husband diagnosed in February, 75 years old. He's been referred for possible transplant. Thoughts on someone doing transplant at this age? We try not to be ageist when we think about transplant, but 75, we have to proceed with caution. Just as we know, as we get older, transplant can be tougher. And I find myself in my clinic very often just giving people permission to not go to transplant. I would be very cautious about that because we have great therapies that don't necessarily include transplant, especially at that age. We have great evidence for transplant in younger patients, 65 and under, and if not even 70 and under. But I can't obviously be much more specific than that, but More often than not, when I'm seeing a 75-year-old patient, I really have to be convinced as to why I would do a transplant, because in most patients, they can do very well with non-transplant strategies. What should a younger person in their early 40s think about in terms of whether or not to pursue stem cell transplant? Starting DRVD therapy, so a quadruplet therapy, which is a great treatment. If it works well, could I consider harvesting and holding? How much do high risk cytogenetics matter in this equation? Well, thank you, JS, for a great question. I'm sorry that someone is fighting myeloma at such a young age. It's a terrible disease, but we know that as I mentioned before, we're getting better at treating it. Um, the short version is that we do have some evidence that people can defer transplant. They can collect their stem cells and wait. We typically potentially pursue that option if two things happen. One, there's a really deep response with, in your case, DVRD. And two, there are not high-risk cytogenetics. I think most of us feel if high-risk cytogenetics are there, it's probably wiser to proceed with the transplant now because we can come at the disease yet another way. We've just learned that high-risk cytogenetics, which about 25% of patients have, it requires more intense therapy coming at different angles. Now, I'm not to say that it cannot be deferred. I don't want to be too concrete, but that's typically how we've approached it. But nonetheless, I do think it's worth considering. I did stem cell transplant about a year ago. That was JS, so thank you. MK writes, I did stem cell transplant about a year ago. Now I'm taking DARA instead of Revlimid for maintenance. The problem is I'm so tired and very sleepy. I sleep all night, but when I wake up, I feel like I did not sleep at all. Can you say anything about the side effect? I think that's worth obviously having to speak to your physician about. It's not a typical side effect of daratumumab that we would see that amount of fatigue from it. If a lot of steroids are being given with the daratumumab, that could be a contributing feature, but that's typically by this point given once a month, and so not likely affecting every night. But that's not something we typically see. I would try to look and pursue at other potential reasons why the fatigue is there. What is the cost of CAR T or bispecific? A great question and hard to quantify because it really depends on the center, the way it's given, the length of time someone's on a bispecific, insurance coverages. Suffice to say, these are not cheap therapies by any means because they are very intense and require a lot of work behind them. The manufacturing, for example, of the CAR T cell therapy and the biological elements of the bispecific therapy. So it's really hard for me. RCB, thanks for the great question, but it's hard for me to be much more specific than that. CS asked the question, can you comment on the need for 24-hour urine tests and maintenance for those not on clinical trials? Is free good enough? That's a great question, CS. It kind of goes back to where someone was before, if there was protein in the urine early on. I still think it's important to do a 24-hour urine at diagnosis. There are some unusual things that we can sometimes detect there. But if someone didn't have 24-hour urine positivity, if there was not protein in their urine at their diagnosis early on, I don't think we need to keep checking it on a regular maintenance schedule. If someone's relapsing, it's part of the restaging, and I think it's good to do. If that was the only way the disease was measured, because some people don't have it measurable in their blood, and it's only in their urine, then yes, it should be done on a regular basis on maintenance, but otherwise not typically. For clinical trials, we often do the urine because it's part of a formal assessment to get certain depths of response, but in a non-clinical trial setting, typically we don't have to repeat it. PB asked the question, I have a 3.66 centimeter hole in my pelvis, no cracks. It's painful and I'm very active, exercise, golf, walking. Is there anything that can be done to cut down the pain? It radiates all the way down to my toes. Otherwise, I'm in good shape. Kidney failure, 2020, dialysis and chemotherapy. Kidneys came back in 3 months. Wonderful. That's great. Transplant 2021, revenue maintenance going well. So I'm so happy to hear about the response and things going well, but I'm really sorry to hear about the pain. And again, it's hard to be very specific, but we try to very carefully approach pain in myeloma, whereby we can sometimes simply give pain medication. Sometimes we can give radiation. What we've learned over time is that our bones do try to heal. We can give a bone strengthening drug along with controlling the myeloma. Controlling the myeloma is critical. Your body will try to heal itself as much as possible as we go through. I can't believe that we have this many questions. I wish I had time for to answer them all. I've come literally to the last minute of our discussion today, and I think I've gotten through just about all of them. Maybe I'll just take one extra 30 seconds to answer this question. I can't help but answer this one. When BG asks me, "What is your outlook for a cure?" I want to be a realistic optimist. So I'm realistic in that we've not achieved a cure yet, and it's not going to happen tomorrow. But I can tell you from when I started that day, when I saw Rich's x ray, when the average patient lived 1, maybe 2 years with myeloma, and we've come so far, we are absolutely closer to the cure than we've ever been, and we're inching closer to it every day. The research that we do at the IMF and with so many others across the world is really guiding us. And I've been involved in myeloma for over 25 years. This has been the most exciting year I've ever seen with all of these new therapies engaging the immune system. And so my outlook is good. My outlook is great. I'm very optimistic. I know it's going to take time, and there's still situations that humble us with such aggressive disease. But I believe that we will achieve a cure, and I will continue to fight so hard to do that. Well, I want to take a moment to apologize that I can't get through all the other questions, but if you do have questions, as I mentioned before, you can submit them to the IMF through myeloma.org or call the info line at 1-800-452-CURE. But I also want to take a quick moment to just thank our sponsors. We've had so many sponsor all of Myeloma Action Month and this activity in particular. 2seventy Bio, AbbVie, Amgen, Binding Site, Bristol Myers Squibb, GSK, Janssen Pharmaceutical Companies of Johnson & Johnson, and Karyopharm Therapeutics, Pfizer, Regeneron, Sanofi, Takeda Oncology, and then even more so the support of just seeing all these people online today, so many of you with so many great questions. Maybe this is an indication we need to do a more regular Dr. Joe Q&A. I'm happy to do that, and I trust that I'll be able to do that more. So again, thank you for joining us tonight. Be well, and we look forward to interacting with you very soon. And please share with us your myeloma story at myeloma.org or mam.myeloma.org. Thanks very much.